It's important to understand what IV therapy does to a patient. Every time we put IV fluids in a patient, we're manipulating their fluid balance and their electrolyte imbalance. So it's important to recognize those imbalances within the system. This diagram gives you an idea of the total body weight in fluids and solids in an individual, in both male and female. So 55% of the female is fluids. 60% of the male is fluids. And then they're further broke down into fluids inside the cell, fluids outside the cell, or interstitial fluids, which is fluids between the tissues itself. And there's only 20% of the fluids that's in the actual plasma of the body. Again, the body fluid compartments, 2/3 of the total body weight is intracellular. Only 1/3 is extracellular, as indicated by the previous graphic. There's only 1 or 2% that is inside, such as the eye, or serous membranes, or in your GI tract, or respiratory or urinary tracts. This nice pie graph gives you a really good idea of how the fluids are divided in the body. Your intracellular fluid is 65%. Again, blood plasma, approximately 8 to 20. Interstitial fluids, only 25%. And then the fluid within the tissues is only about 2%. So you have all these areas that fluids needs to go. They come and they go by osmotic pressure, by diffusion. So you need to realize that we're not just putting fluids into the blood vessels themselves. They've got someplace else they're going to go. This is a good diagram that kind of gives you a good picture of the vein and cells and where fluids are. It also gives you a good picture of the lymphatic system, which also helps carry fluids back and forth and brings them to cells and away from cells. So all your fluids are not just within the vascular system. It's important that our body maintains a balance, okay, a fluid and electrolyte balance. A neutral balance is when we have equal amount of what we take in, input, as what we put out. A positive balance means our input is greater than what we're putting out. And unfortunately, that can lead to things like edema, congestive heart failure, renal disease. A negative balance is when we don't have a lot of input and it's less than our output. We're putting out more fluids than we're actually taking in, and this can cause dehydration as well as fluid shift in all those areas that you saw previously on the diagram, both in the cells and outside of the cells, causing deficits in all those areas. This diagram gives you a good picture of the average daily intake of water and the average daily output of water within the body. There's about 10% of it that's used for metabolism, about 30% in your foods, and about 60% in the beverages that you drink. Your average daily output in water loss, you lose a little to sweat, you lose a little in your stools. 28% is lost through your skin and your lungs. And water is lost in your urine at about 60%. In understanding IV therapy, IVs have solutes in them, which are dissolved particles. And they're electrolytes, such as sodium, potassium, calcium, hydrogen. There are also ions in there, chloride, bicarb, potassium, phosphates. You also have non-electrolytes in there. Some IV fluids have proteins in them, urea, glucose, such as dextrose. I want you to think of these dissolved particles as, let's say you're at a holiday dinner. Each relative, you have 3 relatives that's bringing a pitcher of tea. One relative brings a pitcher of tea, and you can actually see the dissolved particles in there, the solutes. There's extra sugar just floating around in there. That's a hypertonic solution. And then you have a relative that brings a pitcher of tea, and it tastes just so fine. You don't see any sugar floating around in there, and it's just perfect. That's isotonic. And then you have the relative that brings the hypotonic tea. It's brown, looks like tea, but you can't taste hardly any sugar at all in there. So that would be your hypotonic solution. The body's fluid and electrolyte balance is maintained by three methods. Ion transport, so think of that as like delivery trucks. Water movement, think of like waves. And kidney function, or like a well pump. The tonicity of an IV fluid is basically the dissolved particles that's in the solution itself. The tonicity is based on the fluid that's infused into circulation. It has a direct physical effect on the patient. And again, this is like the three examples I gave you with the pictures of tea. Isotonic, hypertonic, and hypotonic. Isotonic stays in your mostly in your blood vessel, and it increases your blood pressure. The hypertonic solution has more particles in it, and it draws fluid from all those other areas that we looked at before in the diagram. All those extracellular tissues, all the cells. It'll leach out fluid there and draw it into the vascular system. The hypotonic solution that's delivered in your blood vessels will actually leave the blood vessel and go bathe those cells and bathe those tissues outside of the bloodstream. This is a blood cell in an isotonic solution. It's that nice little red blood cell with the little sunken concave center. Looks perfectly normal, and it loves being in an isotonic solution. This is a cell in a hypertonic solution. What happens is a hypertonic solution will drain the cell of all the fluid that it has, and the cell will burst. This is a cell in a hypotonic solution. Okay, what has happened here is you'll notice that the cell is swollen. You can no longer see that little sunken concave place. And this is damaging to the cell as well. The movement of fluid in the body, you always remember where sodium goes, water will always follow. For example, if you eat something salty, you always want to drink water. It's the easiest way to remember it. By using diffusion, there is a movement of particles down a concentration gradient. For example, let's say you spill something at a holiday meal, throw down a paper towel, and you'll notice how the liquid will run up the towel. That's diffusion. Osmosis is diffusion across a water membrane. For example, those coffee filters. The only way you can make coffee is when the water goes in there, bathes the coffee cells, and pushes it through that membrane. Active transport is a movement of particles up a concentration gradient. This requires energy to do. So think of like the little delivery truck. You have to actively load it up in the truck and drive it up that hill to get it there. This diagram here is just to give you an example of how much pressure is going on. You have pressure that's in the blood vessel. You have pressure from the tissues that's pressing on it as well. So you have pressure in the blood vessel itself pushing outward. You have pressure from the tissues and the cells around it and surrounding it, pressing down on it. So this is what the body has to overcome to move fluid and electrolytes. Regulation of body water is also influenced by hormones. One hormone, antidiuretic hormone, and thirst, decreases the amount of water in the body, increase the amount of sodium in the body, and it changes the blood osmolality, in other words, the concentration of all those solutes in there. It can also decrease the circulating blood volume that the person has. This hormone stimulates certain receptors up in their hypothalamus gland, and it releases these chemicals that tells you have an increased thirst and you want to drink. The kidneys also play a role in fluid and electrolyte balance. This is an example of what goes on in your kidneys. The blood gets pumped through all these vessels. It gets filtered through these little tubules, and then it goes out into your down to your bladder, so you can get rid of it as urine as well. And if there's any damage in this area here, we're not going to have the ability to manage our fluid and electrolytes like we should have. And sometimes they need to be supplemented by IV therapy. When the body tries to manage fluid and electrolytes, the kidneys or hormones can be utilized to increase water consumption, or also to conserve water, in other words, not put out a lot of urine. Increase water in the body, we can increase the volume that's circulating in the blood vessels, and we can decrease the sodium concentration as well. Kidney dysfunction, hormone dysfunction, traumas, fractures, gunshot wounds, any type of trauma actually can cause a dysfunction, and the body decreases the amount of water in the body. You can lose it through loss of blood. Increases the amount of sodium in the body, which also increases the osmolality, again, all those particles and concentrations. And it also decreases the circulating blood volume. Edema or swelling is the accumulation of fluid within those interstitial spaces within the tissues, as we saw in the diagram previously. This is usually caused by an increase in pressure, hydrostatic pressure, lower plasma osmotic pressure, those pressures that we were looking at in the diagram, increased capillary permeability, in other words, the membrane has got holes in it and they're all leaking everywhere. Or you can have your lymphatic systems, which is close to your cells that you saw in the diagram previously. They can be obstructed with material in there. The hydrostatic pressure can be caused by a venous obstruction. For example, the patient can have a thrombophlebitis in their vein from maybe a previous IV or an injury. They can have a hepatic obstruction, an obstruction of some type in their liver. They could have tight clothing on the extremities. Maybe they have edema and swelling and those socks are cutting off the circulation, or from prolonged standing. And they may have large venous insufficiency, varicose veins. You can also salt or water retention. You'll see that in congestive heart failure or patients that have renal failure. For a decrease osmotic pressure, usually there's a decrease in the plasma albumin, which is plasma proteins. You'll see this in patients that have liver disease, alcoholism, or malnutrition. Plasma proteins are lost in the kidneys as a result of kidney disease. Maybe they have diabetes or have some type of disease that has damaged their kidneys, hemorrhage, burns, any kind of open wounds or cirrhosis of the liver. An increase in capillary permeability can be caused by an inflammation, an inflammatory process, infection, some type of an immune response. Your lymphatic channels, they can get blocked by, trauma, surgical removal, any kind of infection that involves the lymphatics. They're trying to clean things up and get stuff out of there, or anything that can cause lymphedema. Your lymph glands get swollen excessively, fluid filled, and it doesn't empty. With fluid accumulation, you can get an increased distance for diffusion. Okay, and this impairs blood flow. You have slower healing. You have an increased risk of infection, increased risk for getting bed sores or any kind of pressure sore that's any kind of over a bony area. And there's also psychological effects as well. We have to be careful with edema because edema of specific organs can be life-threatening. to the larynx, the brain, and the lungs. Water gets trapped. It's unavailable to be used for, metabolic processes, and it can result in dehydration and shock, for example, as in severe burns. Let's talk about some electrolyte imbalances. Your sodium, you look on the lab result, it should be somewhere between 136 to 145. Sodium likes to hang out with things like chloride and bicarb to kind of help neutralize them. It's very important in regulating water balance within the body. It's also important in nerve and muscular function. So when you have patients who are exhibiting nerve problems or muscle problems, one of the things you want to look at here is their sodium level. Regulation of sodium is done by the renal tubules. Reabsorption is affected by some of those hormones we talked about: aldosterone, renin, peptides. Potassium is one of the major intracellular electrolytes. It's very important because it controls the opening and closing of the gates within the cell itself, or your membrane potential. It regulates fluids, your electrolyte imbalance inside the cells, and also affects your pH balance. Regulation of potassium is done through the kidneys. It's influenced by those hormones we talked about, aldosterone and insulin as well. So if you have patients who have chronic or acute kidney disease, it will definitely affect the potassium levels of the patient, and this will be reflected in their lab results. You can have alterations in water balance when the total body weight changes. It's also accompanied by a change in the electrolytes as well. This can be caused by a loss of plasma, such as bleeding, a decrease in your isotonic fluids, weight loss, dry skin, dry mucous membranes. They have a decreased urine output, a rapid heart rate. The veins on the side of the neck will appear flattened or sunk in, and they may have a normal or a decreased blood pressure, or maybe even shock. A patient who may have isotonic fluid excess is a patient who's had excess IV fluids. So it's very important that we calculate them and we monitor them regularly. They could also have some type of a tumor or a problem that causes them to secrete too much aldosterone. Remember that hormone that helps regulate fluid and electrolyte balance. Or in the effects of drugs. For example, a cortisone drug. These patients get hypovolemic, they get weight gain, decrease in their hematocrit level, they get diluted plasma, so therefore their plasma proteins are diluted. The veins on the side of the neck will be distended or stand out. They'll also have an increase in blood pressure. This can lead to edema, which is where you get that capillary membrane permeability. It can also lead to pulmonary edema, not just edema in your ankles, but edema in your lung tissue as well, and heart failure. Patients who have electrolyte imbalances involving sodium, it's what we call hypernatremia, which is high levels of sodium. So the lab result will be greater than 145. And this is caused by a decrease in water or an increase in sodium within the body. The water moves from within the cell area to outside of the cell area, and this causes the cells to dehydrate. This graphic gives you a good picture of the cell membrane and how water is lost from the extracellular compartment or outside the cell, and how the solute concentration increases outside of the fluid compartment. And it shows you how water leaves from the intracellular space into the outside fluid compartments. Hypernatremia, or too much sodium, is due to perhaps a hypertonic solution. Maybe the IV solution is hypertonic. It can be also caused by oversecretion of aldosterone or a loss of pure water, such as sweating or a chronic fever, or they have a respiratory infection where they're losing a lot of water vapor during their respirations, or a patient that may have diabetes and they have polyuria, so they're urinating a lot, or insufficient water intake. Some clinical manifestations of hypernatremia, or too much sodium. Patient will have lethargy, tiredness, fatigue, thirst. They may have some neurological dysfunctions due to dehydration of the brain cells. They'll also have decreased vascular volume. You won't see their blood vessels very well. The treatment of hypernatremia, we need to lower that sodium content level. We usually use a isotonic salt-free IV fluid solution, oral solutions preferably, if at all possible. Hyponatremia, which is a low sodium level. We have an overall decrease in the sodium in the extracellular space. There's usually two types, dilutional, which they have a fluid overload, or depletion, we've used it up. Sodium loss is usually due to diuretics, patient that might be on a diuretic, chronic vomiting, or maybe they have a disease that causes chronic diarrhea, or a decrease in aldosterone due to a tumor or disease process, or a decrease of sodium intake. In dilutional hyponatremia, you can have renal dysfunction with an increased intake of hypotonic solutions such as maybe IV therapy. You can have excessive sweating, maybe due to a disease process. Increased thirst leads to an intake of excessive amounts of just pure water. There's also a syndrome called SIAD, which is an inappropriate antidiuretic hormone. You'll find that in renal failure as well. Severe congestive heart failure, cirrhosis, they all lead to impaired renal function. And as you saw in the diagram, if you have impaired renal function, then you're going to have impaired ability to excrete water appropriately. Also hyperglycemia, which attracts water. Some clinical manifestations of hyponatremia, or low sodium level, can develop neurological symptoms such as lethargy, tiredness, headache, confusion, apprehension, irritability, depressed reflexes, seizure, and coma. Some of the muscle symptoms are cramps, weakness, fatigue. Some of the GI symptoms are nausea, vomiting, abdominal cramps, and diarrhea. And the treatment is to limit water intake or discontinue certain medications that's causing this to happen. Hypokalemia, which is low levels of serum potassium. You need to be aware if they're a diabetic, because the insulin gets potassium and takes it into the cells. And when you have a diabetic that's in ketoacidosis, the hydrogen ion replaces the potassium, and then it's lost in the urine. Also, what we call beta-adrenergic drugs, such as epinephrine or some of these inhalant drugs that we use for COPD and asthma, those will also cause hypokalemia. Some causes are decreased intake of potassium, or a condition that causes an increase in potassium loss, such as chronic diuretic use, patients call them water pills, an acid base imbalance, any kind of trauma to the body, stress, increase in aldosterone secretion, or just a general redistribution of the intracellular fluid and the extracellular fluid. The body might be trying to maintain a balance and not doing a very good job of it. Some clinical manifestations of hypokalemia are neuromuscular disorder, weakness, kind of flaccid paralysis. Severe ones are respiratory arrest. Some early signs are constipation, heart rhythms, postural hypotension. They'll be sitting down and go to get up, get lightheaded, maybe even faint and fall. Can cause a cardiac arrest. The treatment is to increase potassium intake, but you have to do it very slowly, preferably by foods and not by IV therapy. But there are indications where sometimes potassium does have to be replaced by a licensed person by IV therapy. Conditions of hyperkalemia, or too much potassium, are levels greater than 5.5. You need to check these individuals for renal disease. This can be caused by massive cellular trauma, automobile accidents, that type of stuff. Insulin deficiency, not taking their insulin, a disease called Addison's disease. Potassium-sparing diuretics. The individual's water pill may be purposely prescribed to maintain their potassium level. A decrease in the blood pH, so the patient is acidotic. Exercise causes potassium to move out of the cells. So individuals that over-exercise or exercise habitually have to be careful. Some clinical manifestations of hyperkalemia. The early stages are hyperactive muscles, paresthesias, weaknesses. Late symptoms are muscle weakness, flaccid paralysis, changes in the EKG patterns, heart dysrhythmias, low heart rate, heart block, and eventually cardiac arrest. Some treatments for hyperkalemia, as if time permits, we need to decrease the intake of potassium and increase the renal excretion if at all possible. Insulin and glucose help to decrease the potassium, so you may be giving IV therapy that has glucose in it. A licensed personnel would administer bicarb or calcium to help counter the effects it may have on the heart. In calcium imbalances, most of this is in the extracellular fluid, the fluid outside of the cells. It's regulated again by hormones, parathyroid hormone. An increase in blood calcium is stimulated by your actually bone material, your osteoclasts. Increased GI absorption and renal retention. Calcitonin, which comes from the thyroid gland, promotes bone formation, and it also increases renal excretion. Hypercalcemia, or too much calcium, results from a disease that affects the parathyroid or the thyroid itself. It can be caused by renal disease, an excessive intake of vitamin D. Sometimes you have individuals that take multiple different kinds of vitamins and they're just stacking vitamin D one on top of the other. A syndrome called milk alkali syndrome. Certain medications, drugs, can cause an excess retention of calcium. Certain malignant tumors or tumor products, when they start to break down, when they have chemotherapy, or tumor growth in bone cancers. When you have an excess of calcium, you also have an excess of phosphates as well. They kind of go hand in hand. Some of the effects, they're not really specific. They're just in generalized weakness, tiredness, lethargy, increased formation of kidney stones. You can get pancreatic stones. They'll complain of muscle cramps, low heart rate, cardiac arrest. They'll complain of pain, generalized pain, GI problems such as nausea, constipation, abdominal cramping, diarrhea, and also metastatic calcifications for those individuals that may have metastatic cancer. Hypocalcemia, or not enough calcium, can cause hyperactive neuromuscular reflexes. It can cause convulsions. It's usually caused by renal failure, a lack of vitamin D, some types of suppression of the parathyroid gland, a hypersecretion of calcitonin, which can be caused by tumors, certain types of malabsorption states in the GI tract, abnormal intestinal acidity or an acid-base balance, a widespread infection or an inflammation of your peritoneum, abdominal area. Hypocalcemia, you don't even need a lab test for this. You can actually check for this at the bedside. There's a sign called Chvostek's sign. If you take your finger and tap it at the angle of your jaw, you'll have a muscle reaction in these individuals, and they'll make like a wink, or it'll pull towards that angle of the jaw, like a muscle spasm. There's also, you can use a trousseau sign. You can put a blood pressure cuff on an individual and go to pump it up, and you'll notice that their hand will pull in towards their body and make like a C, and you can ask them to straighten it and they can't. The treatment for low calcium levels is IV calcium for the acute episode, and then we give them oral calcium and vitamin D for the chronic problems.